This talk will give a summary of possible ultrasound interactions and bioeffects which can be generated using diagnostic ultrasound. In addition, it will present the current guidelines for the safe use of ultrasound for routine clinical diagnostic practice. The PowerPoint has been prepared by ECMAS, the Safety Committee of EFSIM. The reasons why we should be concerned about the safety of ultrasound are threefold. Firstly, the range of clinical applications is expanding. Secondly, the number of patients undergoing ultrasound examination is increasing, and much of the epidemiological evidence of safety comes from in utero exposures from early scanners with much lower outputs. And thirdly, new techniques with potentially higher acoustic output levels are being introduced. So what do we mean when we talk about bioeffects? Bioeffects are the effects seen when ultrasound interacts with biological molecules as it passes through tissue. In the context of the safety of ultrasound, we are concerned about bioeffects which may cause a problematic change either within cells, genes, or DNA. The mechanisms of action under which bioeffects can potentially occur are thermal and mechanical. The heating generated by ultrasound is related to the spatial peak temporal average intensity, otherwise known as ISPTA, and measured in units of milliwatt per centimetre squared, or by the acoustic power measured in milliwatt. For the mechanical effects, the most relevant mechanical mechanism is probably cavitation, and peak rarefactional acoustic pressure or negative pressure is important and is measured in kilopascal or megapascal. Ultrasound passing through tissue is attenuated. The ultrasound that is scattered and reflected back to the transducer is used for imaging, while the absorbed ultrasound is transferred to heat. Only a small proportion of the transmitted ultrasound signal is used to make the image. The remaining energy stays in tissue and is absorbed, leading to heating. Temperature rise depends on the absorption coefficient, which is proportional to frequency, the exposure duration, and the number of pulses per second, the pulse repetition frequency. Different modes of ultrasound use different exposure conditions. This slide shows the approximate hierarchy of power output for different modes, and therefore the order in which potential for heating becomes important. Looking at the different imaging modalities, due to the pulse generation and high pulse repetition frequency required, shear wave elastography has the greatest heating potential. There is a need for standard relevant measurement or calibration method to assess bioeffects in terms of ultrasound dose. Intensity is defined as the energy crossing a unit area in unit time, the flux. However, it cannot be measured directly. Intensity has spatial and temporal variations. Pressure, however, can be measured directly. Of course, one must also consider effects due to the self-heating of the transducers. This self-heating is due to the loss of energy when converting from electrical to acoustical power. Additionally, depending on the imaging mode used, the increase in transducer element temperature can vary. Here we can see three images demonstrating the temperature rise for a linear array probe under B mode, pulse Doppler, and color Doppler modes. Consideration of transducer self-heating is especially important for intraluminal and intracavity transducers. So the biological effects of heat depend on the temperature rise and duration of this temperature rise. The tissues which contain a large component of actively dividing the cells are most sensitive to the effects of heat, so the embryo and fetus are most likely to be at risk. Acoustic cavitation is a mechanical effect of ultrasound. It describes the formation and/or the activity of gas-filled bubbles in an ultrasound-exposed medium. In stable cavitation, at relatively low acoustic pressure, bubbles oscillate. At higher acoustic pressures, inertial cavitation can occur, where bubbles can expand too far, then collapse very rapidly, releasing enough energy to damage the surrounding tissue. Cavitation bubbles have an enormous amount of energy associated with them, as seen by the release of a champagne cork, pitting of a ship's propeller, and the hole seen in a rat liver following ultrasound exposure. So if we now consider the parameters which affect the heating and cavitation effects, heating increases with increasing contact time, output power and frequency, and narrowing of the scanning sector and deeper and more focal zones. For cavitation effects decrease with increasing frequency. That is, cavitation effects increase with lower frequencies, increasing power output, and increasing contact time. These are rule of thumb. In practice, each scanner may perform slightly differently, and so it is important to watch the on-screen indices. Other factors which may indirectly influence heating and cavitation include range gate width, range gate depth, and Doppler velocity range. However, the receiver gain will have no impact on the output parameters, so therefore optimize your time gain compensation and overall gain settings. The World Federation of Ultrasound in Medicine and Biology published its safety statement in 1997, stating, "A diagnostic exposure that produces a maximum in situ temperature rise of no more than 1.5 degrees centigrade above physiological levels may be used clinically without reservation on thermal grounds." Also, a diagnostic exposure that elevates embryonic and fetal in situ temperature above 41 degrees centigrade, that is 4 degrees centigrade above normal temperature, for 5 minutes or more should be considered potentially hazardous. Two safety parameters are displayed on the ultrasound screen to estimate the risk potential depending on the chosen scanner settings. These two parameters are known as the mechanical index, MI, and the thermal index, TI. These are important as different scanners respond differently to the controls available to the user, so these indices give a real-time indication of what is happening in tissue. The thermal index is an on-screen guide of the potential for tissue heating and is defined as the ratio of the acoustic power output to the acoustic power required to produce a 1 degree centigrade rise in temperature. It is an estimate of the tissue temperature rise in degrees centigrade which might be possible under reasonable worst-case scenarios. On scanners, it must be displayed from a value of 0.4 if it is capable of exceeding a value of 1. Depending on the scanning application selected, different tissue models are internally used to estimate the thermal index. There are 3 thermal indices which can be used. TIS, when soft tissue is in the path of the ultrasound beam, and TIB, when bone is at the focus of the ultrasound beam, or TIC, when bone is near the transducer surface, such as when scanning the cranium. The mechanical index is the other index which is shown on the ultrasound screen and is a guide of the likelihood and magnitude of non-thermal effects. The mechanical index is equal to the ratio of the peak negative pressure expressed in megapascal to the square root of the acoustic working frequency of the transducer, which is generally taken to be the central frequency of the transducer and is expressed in megahertz. The factor C is included to make the mechanical index a dimensionless parameter. This example shows different power and gain settings while imaging the same subject. The image on the left-hand side has high power output, with an MI value of 1.1 and low gain at -2, while the image on the right-hand side has lower power, MI equal 0.5, and high gain equal to 15. The quality of the images is similar, and arguably the image with lower power and high gain values has better spatial resolution, and from the point of view of safety, these lower power settings are preferable. For diagnostic scanning during pregnancy, there is no scientific evidence of ultrasound-induced biological effects, and therefore no reason to withhold diagnostic scanning during pregnancy, provided it is medically indicated and used prudently by fully trained operators. During pregnancy, fetal bones become increasingly mineralized, and therefore the possibility of heating sensitive tissues such as brain and spinal cord increases. Consequently, extra vigilance is advised. For obstetric scanning, the British Medical Ultrasound Society has linked the displayed value of TI to maximum scanning times. This helps to minimise the potential heating risk in routine obstetric scanning. For 3D scanning, no additional safety considerations need to be undertaken, especially if there are significant pauses during a scanning to study or manipulate the reconstructed images. However, 4D imaging involves continuous exposure, and it is necessary to guard against prolonging examination times unduly beyond that necessary for diagnostic purposes. There are many epidemiological studies related to the safety of ultrasound, some suggesting associations between ultrasound exposure and gestation or later development. Other studies indicate effects of ultrasound exposure in some animal models. And we should keep an open mind as new techniques often involve innovative pulsing regimes producing higher acoustic outputs. Scanners which are smaller, lighter and less expensive are often used by personnel with insufficient training, and the media and public interpret some outcomes incorrectly or imprecisely, and such findings can attract an audience. But there are reasons why we should not be worried. A statistical association does not imply a causal relationship in general. Some of these published studies show statistical flaws or methodological errors. From most of the studies, the biological plausibility of this association is questionable. Some studies contain experimental settings and exposure durations not commonly used by skilled personnel, and safety committees regularly evaluate these studies. A final word on ultrasonic contrast agents. These are gas-filled encapsulated microbubbles used to aid ultrasonic diagnosis in difficult-to-image patients. However, ultrasonic contrast agents are not licensed during pregnancy, and caution should be used when they are used in tissues for which damage to the microvascular is important, such as the eye, brain and neonates, and also in patients with severe coronary artery disease and pulmonary hypertension. In general, the advice when using these agents is to keep the mechanical index low and avoid long exposure times. If you need further and more detailed information about specific topics in which you are interested, please go to the following websites. Thank you very much for your interest in safety-related topics.